remembered me from Vest Pimps before we fell off the figurative cliff that is fourth year. May or may not have seen me for some of your introductory lectures where I did neurology and resp, and may or may not have seen me loitering this morning because I'm part of MUPPITS. Today I will be covering EMQ and OSCE topics, and for those of you who have seen my respiratory presentation, this is very much a take on from that. The way we'll be approaching today is that I'll be giving you guys an EMQ, you guys will attempt to solve it, and then we'll do some teaching around those EMQs and take it from there. So in terms of EMQ topics, as you guys have probably already realized just from your general exams, they fall into two categories of either diagnostic or management questions. Where is Stacy? Is Stacy here? Beautiful. What time do I have until? No, I'm not gonna. 2:30. Cool. This is not a content-heavy presentation. I'm not going to run you guys through the gamut that is respiratory condition in peds, which is a pretty big topic. I like to go for the money. I like buzzwords, and I know you guys love them too because that's how you get marks on your exams. And anything that is heavily in detail, I omitted because it's just not going to be relevant. The questions you will get will not be super detailed or very esoteric. So in terms of diagnostic questions, we'll be covering respiratory distress in the newborn, Stridor, and respiratory tract infections in kids. And something you'll be expected to know to a fairly good detail is the management algorithm for asthma, both in the acute setting, so someone who comes into ED with an acute flare of asthma, but also your step ladder for patients who have chronic asthma and how you up titrate their medication. Love you too. Cool. I'll have you guys know I actually made this mistake the first time I presented as well a few months ago, so I actually needed that to happen earlier. And in terms of OSCE topics, we'll go through the diagnostic dilemma of a kid with a wheeze, as well as a bit of more knowledge so that you'll be able to do a counseling station related to asthma and cystic fibrosis. So we'll begin today with this clinical picture of respiratory distress in the newborn, or a little baby who's just really struggling to breathe. Now, when you see this, I like to be systematic and start head to toe. And so like you can look for features such as head bobbing, nasal flaring, grunting, recessions. And the general trend is the more features that you see, the more sick this kid is. And the idea is that we want to diagnose them quicker and get management on board as soon as possible. The only problem is that these signs are fairly nonspecific, and there's quite a few differentials that you can consider that could be causing this picture of a little baby having difficulty breathing. So the features that will help you differentiate them on your EMQs generally will be the risk factors, and so that mainly perinatal, antenatal, and like birth risk factors, as well as if they have a chest x-ray, the big buzzwords that you see on them. So we'll start off with our first question. So have a read. I'll give you guys 30, 40 seconds, and if anyone's comfortable, shout an answer at me. I heard D. Cool, yeah. Any other takers? Any different options? Cool. Anyone have any other suggestions as to what they think the answer is? Yeah, Masada, what's up? Respiratory distress syndrome, which is the same as surfactant deficient lung disease. We'll get onto that in a second, but it's the same condition with 3 names. Does that answer your question? Yeah. So the answer is in fact D. As you guys have probably realized by now, a lot of peds is hyper buzzwordy, and often the diagnosis is put on a platter for you, and it's just a matter of know the buzzword, you know the answer. In this case, the 2 big ticket risk factors here is that this is a post-term bub who's had meconium state and liquor. So just a real quick revision of meconium aspiration syndrome. Generally, remember that meconium is the baby's first poo, and the older the gestation the baby is, the more likely they'll pass it in utero, aspirate it, and then get an irritative pneumonitis from it. So meconium aspiration to begin with, I thought it was an infection of the lungs. It's not, it's just the initial irritation that they get. And so like we had a chat about those 2 big risk factors, and the classic buzzwords that you will see are hyperinflation or air trapping, streaking, patchy infiltrations, and atelectasis, if they do describe it like that on your EMQ. Now, because you more often than not, if you can actually see it obstructing their airway, we should just suck it out. And if they otherwise can just absorb it, and the respiratory distress will settle on its own. Question number 2. Do I have any takers? G, what's the big giveaway? Gurgling noises. Do vesicular breath sounds gurgle? No, they do not. So the answer is G. So the key hints here is that the gurgling noise is perhaps the biggest giveaway. It's bowel sounds in the chest. The kid's been lost to follow-up, which means that if we had any chance of picking up antenatally, this kid didn't have the opportunity, which is why it was picked up at birth. And the increased work of breathing is because of the fact that they just don't have lungs to work with, and even ventilating whatever's left of it isn't going to significantly help them from that point of view. So a quick recap of congenital diaphragmatic hernia. You probably will never see this in your time as a med student unless you do more peds in the future, but it's incredibly buzzwordy for your EMQs and very specific. So this is that kid who is not responding to any form of resus. You hear the bowel sounds in the chest, and what I didn't describe in my EMQ, but you might also see in your EMQ, is a scaphoid abdomen. So it looks empty because the bowels have moved from the abdomen to the chest. You will just simply see bowels in the thorax, and it'll be you'll see the intestines up in either left or right hemithorax, and this needs to be corrected surgically. Cool. Question number 3. Cool. I have any other takers for anything different? What led you towards TTN? Cool. That's a risk factor. Nothing else, and that's the key thing here. So remember that transient tachypnea of the newborn is a diagnosis of exclusion. So before you jump at it and you see that x-ray and you're like, oh, it just looks like a bit of fluid in the lungs, remember that we need to make sure it's not other things. And the thing that leads us towards a diagnosis is first making sure that it's not anything else, and then looking for the risk factors for TTN. So the fact that mom's had a completely normal course with her actual pregnancy, GBS negative, so we don't think it's of any form of infection. And otherwise, the baby was well in terms of the actual delivery. So this tells us this is a fairly unremarkable birth and a fairly unremarkable pregnancy. And then the risk factors we have for that is the C-section. And the pulmonary edema is the second factor that leads us towards TTN. So remember, just for these EMQs, it's really tempting to just go for a buzzword thing. This is probably one of the few diagnoses you want to just have a step back, look and make sure, okay, it's not anything else. And then, okay, cool, I'm happy this is TTN. So just a really quick recap, it's the most common cause, but don't be misled by that when you're thinking of other things on your EMQs. And remember that the placenta is what's doing the oxygenation for baby's blood until they're born, at which point the lungs take over. And all that's happened here is that the fluid that they're normally meant to resorb hasn't been resorbed fast enough. And so when they try to ventilate and oxygenate themselves, they don't do it adequately. So essentially, because this is just a physiological process that has failed to occur at a rate that would normally happen, we can just support them, give them oxygen, put them on their back, and wait for it to resolve. And if it doesn't resolve within the first few hours or up to 24 hours, then we can start going down the path of, is there another pathological process going on? Because fundamentally, I like to describe it similar to a heart failure pattern, because fundamentally, we have fluid in our lungs when a fetus is as normal physiology, but when fluid accumulates, it'll begin in the alveoli, then seep out into the lungs, which is why you can get the pulmonary edema and then the pleural effusion if they do have that, but reasonably uncommon. Cool, and I think this is the last distress question I have. Yep. So any other takers for options other than B? People pretty happy with B? What's the big giveaway here? Preterm, good. Beautiful. If you guys take nothing else from this slide, it's literally you see ground glass appearance when we can almost certainly jump on hyaline membrane disease. So ground glass, 32-weeker, this kid doesn't have surfactant in his lungs, probably hyaline membrane disease. So just something to clarify, because I remember being taught of the name as hyaline membrane disease, and for the longest time, I thought respiratory distress syndrome was the overarching term for any kid any newborn with respiratory distress. It actually specifically relates to this particular diagnosis, which is why if we want to be technical with the words, we will call it the presentation respiratory distress in the newborn. And fundamentally, it's due to lack of surfactant in their lungs. So this can either be because they're prem and they just simply haven't matured enough to have their own endogenous surfactant production, or because mom has a condition like gestational diabetes, which inhibits surfactant production. The pathophys, I honestly have no clue. So the two descriptions that you will see that are pathognomonic for it are either that ground glass appearance that you will see on the lungs that's diffuse, or similarly, a different description but to the same effect, homogeneous diffuse granular opacity with no isolated area of opacity. And that's basically telling you that because it's spread all over, it's less likely to be a pneumonia because it's not patchy, it's not in parts of the lungs. And so from there, the management, if we can anticipate a preterm birth, we can give mom steroids so that, as you guys have probably have done women's already, so we can induce surfactant production in baby. If we do not anticipate this and we think that, okay, this is an unexpected preterm delivery, we can actually put an ETT in and give surfactant directly into the lungs. And then we can support the ventilation via low flow nasal pongs, high flow nasal pongs, CPAP. Do they need to be admitted to NICU? Those sorts of things. Stuff making sense, guys? Cool. Cool, so now we're moving on to the next set of questions. Hit me, guys. Figuratively, you guys can punch me later. Croup? Any other takers? What was the big giveaway? I know it's staring us all in the face. Beautiful. Now, why isn't this, for example, acute epiglottitis? Acute epiglottitis can also have a barking cough. Good. Yeah, no, the kid's well, reasonably well. He's sick, but he's reasonably well. So saturating well, not severely working hard to breathe, all that sort of jazz. So you guys look at that, you see a kid who's sick, but not that sick, has that barking cough, we can call this croup. So croup in one slide, laryngotracheobronchitis, and that's usually a viral inflammation of the airways. There are bugs other than paraflu, but you should be aware that it's the most common bug. Something that they might do for your EMQs is that instead of listing lots of different diagnoses for acute stridor or for airway infections, you might get multiple EMQ options that just have bugs, and then they'll give you the clinical synopsis for that shouts croup at you, but the options will be bugs, and at which stage you'll be like, oh, this is paraflu. So the history in a nutshell, you have that viral prodrome followed by the triad of hoarse voice, which generally corresponds with inflammation of the larynx, stridor, which corresponds to inflammation of the trachea, and the barking cough. People have seen croup in ED, yes? You guys have heard the barking cough. It is very distinctive. I remember the first time I heard croup with my reg, my reg heard the cough, and he was like, yeah, this kid has croup. Before we even saw them, I was like, oh, cool, it is a spot diagnosis. And so generally, if it's a clear-cut case of croup, we don't do any investigations. Skip this step. In terms of examinations, there are four main parameters that we look at to stratify the severity. So behavior, which is their mental state. Is this kid alert? Is he tired? Is he miserable? Is he lethargic? Stridor, so is this stridor at rest versus on exertion? Respiratory rate, and then accessory muscle use in terms of that work of breathing. Now, we could also talk about oxygen stats, but you need to completely obstruct your upper airway to see any changes of desaturations in the kid. And if they're desaturating with croup, they have either really severe croup, consider an alternative diagnosis like acute epiglottitis, and they need to be intubated because they're obstructing their airway at that stage. Based on that severity, we can then titrate the management. If the barking cough is the only feature that they don't have stridor, we can just let them be, educate the parents, send them home. If they're mild to moderate, we can start them on steroids, then reduce the time it takes for that inflammation to settle. And then finally, if we're worried about severe croup, we can give them nebulized adrenaline to buy them time and intubate them if we do think they're obstructing their airway. Cool. Question number 2. By the way, this mom's name is Karen and she wants to speak to your manager. This is natural selection at its finest. I'm sorry. No, I'm not sorry. Cool. Hit me, guys. What's the answer? Epiglottitis. G, beautiful. So yeah, the crux here is that this is a kid, so something to be aware of for your EMQs and something to not just simply jump at is that I could have made this a stem that also said that this kid had a barking cough. And the idea is that the barking cough is just a feature of inflammation of the trachea. So any inflammatory cause of stridor can feature with a barking cough. The key feature that differentiates croup from things that make kids really sick, like acute epiglottitis and bacterial tracheitis, is that your kid is overall toxic looking. And what I mean by that is they're not energetic, they're desaturated. Oh, why did I put, no, he's saturating well. They're really struggling to breathe. And this tells you like, okay, this is probably not viral. This kid's probably quite unwell with something else. Cool, so this is acute epiglottitis. So pretty uncommon unless your mom's Karen and you haven't been vaccinated. We worry about it because these kids obstruct their airway. It's caused by Hib. And even though this isn't technically the right way to remember the symptoms, I like to remember the 4 Ds of acute epiglottitis, which is drooling, dysphagia, dysphonia, and distress. And one feature that will help you differentiate it from bacterial tracheitis, if it's in your EMQs, is that they will have an absence of cough in the latter. So in terms of how you manage them, if you had to talk through an not an EMQ, an OSCE spiel about how you would do it, start with your disposition. You know, this is a kid that needs to be admitted to hospital. Go through your ABCs. So airway first. If this kid was at risk of obstructing their airway, intubate them. So breathing, circulation. I get IV access and send off blood cultures. Treat the underlying cause, which is giving them a broad spectrum antibiotics to cover for Hib. And steroids to help dampen down that inflammation. And any contacts we want to, later down the line, once we've got the kid under control, we can consider prophylaxis for the contacts as well to prevent its spread. And something I failed to mention here is that I'm pretty sure this is a notifiable disease. Cool, next question. If you guys are finding these questions easy, that makes me happy because you all will do well. Did I hear A? H, cool, I got worried there. Cool, so inhaled foreign body. So this is very acute presentation of coughing and could present with stridor as well. I should have chucked that in. History of being either playing with or found around an object that a kid could aspirate. And one of the key features that leads you away from infective causes of stridor is that they don't have a fever, they don't have any coryzal symptoms. So yeah, this is inhaled foreign body. Excuse me. Next question. Not that common condition, but you should know for your EMQs because it's very specific. Cool, I heard I. Any other takers? People generally happy with I? Can't hear you, can't hear you. God dang it, I should have had that as an option there. But yeah, so good. So the answer here is in fact subglottic stenosis. So the pathophys in this, sorry, was that a question? Someone raising their hand? No, he's just looking at his chart or something. Cool. So in this case, the pathophys of this is that kid got intubated, airway got scarred. And so because they have a fixed obstruction of their upper airway, they have chronic stridor as a consequence of that. And so the nice thing about this condition is that as the kid gets older, the diameter of their trachea increases, they'll grow out of that stridor. And more often than not, we don't need to go in with a bronchoscopy and ablate it because they'll just grow out of it. Yeah, so I'm pretty sure I don't have a question on laryngeal malacia, but does anyone can just shout at me like the general pattern of laryngeal malacia in terms of how it presents? Worse at night? Yeah, it could be worse at night. What makes it worse? Man, I should not have asked you guys to shout that because I heard nothing. A gobbled mess of 20 people like it. But essentially, I know some people said it. So essentially, because it's a floppy larynx, they end up, when they get distressed, the larynx will flop and becomes like make stridory noises. And then when they're settled, not much air is passing through, so it's settled. So they'll have no stridor at rest, and when they're crying or otherwise distressed, they will have stridor. Cool. So just a very quick recap of noises that kids make with their upper airway. If it sounds like snoring, we call that stertor, and it corresponds to some form of obstruction superior to the larynx. These kids are unlikely to obstruct their airway. And if it sounds like a classically described as a high-pitched inspiratory noise, we call that stridor. That's between the larynx and the bifurcation of the trachea. And you can broadly divide your differential. So this is more thinking about your OSCE approach to it as acute causes of stridor and chronic causes of stridor. In this slide, I've basically summarized six really common causes of stridor. I like the mnemonic CRABBY. And the idea is that I've given you the main dot points you need to look for that will lead you towards a diagnosis in your EMQs. Or even for, you could get, I think it'd be pretty reasonable to get a stridor station for your OSCE, where a kid comes in, mom says their presenting complaint is kid's has had a fever and had a bit of noisy breathing, please assess them. And these are the sort of features that you're looking for both on history and examination that would lead you down each path. Cool, I don't think there's anything else that I want to clarify here, but that's essentially all these 6 conditions in a nutshell. And then for differentials for chronic stridor, like we talked about with laryngomalacia, noisy when crying or upset, and then absent when they're settled. Something that you might see in EMQ books is that they might describe cogwheel stridor. I honestly have no idea what this means. It's a buzzword, let's roll with it. Laryngeal web, it can be a little bit weird because I tried to find a feature that would differentiate it from laryngomalacia, and I really couldn't in my notes. But hopefully you don't have both laryngomalacia and laryngeal web as options in the same EMQ. If you do, just go with laryngomalacia if they're really young, if they were preterm or really young. And then subglottic stenosis, like we talked about, some reason for their airway to get either inflamed or injured, stenosed. And therefore, usually the classic history that you'll get on your EMQ will be prem, intubated, they now have chronic stridor. Cool, yeah, next question. Cool, I heard a pertussis. Any other takers? Anyone think it's anything other than pertussis? And if so, why? Yeah, just like you can tell me I'm wrong, I'm not. Cool. But the person who said it is correct. So it is in fact pertussis. So the features here that tell you that this is pertussis is the coughing fit. So, you know, your paroxysmal episodes of cough, the kid goes cough, 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 cough. They can't breathe while they're having that coughing fit. Take that deep breath in to try and catch air, and that's the characteristic whoop for the whooping cough. And during those episodes, this kid is having some features of like, you know, becoming plethoric and lethargic because he's just getting tired out by it. And then the prodrome is what we described, that RT-like illness 1 week ago. So some kids can present with an RT-like illness, and it's actually possible, unlikely, but possible for them to have Croup, pertussis, and it's just a matter of asking whether or not anyone else, you know, the only real things you can do to screen whether or not this kid is high risk, if you didn't get those first few questions of, those first few features of coughing fits, is whether or not, you know, have they been exposed to anyone who had whooping cough recently, or anyone at school who's been or prep or kinder who's had coughing fits would make you think, is this more or less high risk of a child? So whooping cough, bordetella pertussis, more common in adolescents and young kids, but it's fatal to infants, which is why we care. If you have an OSCE station about pertussis, be able to describe the 3 phases. So prodromal, sounds like it's just a common cold or an upper respiratory tract infection. Next minute, a week passes and they now have their spasmodic coughing episodes, and they might have complications from that, such as like vomiting, cyanosis, nosebleeds, subconjunctival hemorrhages, and we worry about it in infants because they get tired out by it. And then the convalescent phase of it, which goes for several months, and the only feature that they have is just a dry, persistent cough. Complications that you should be able to tell the parents about what to be worried about if then when to come back. Things that we can see and won't kill the kids, some subconjunctival hemorrhage, nosebleeds, poor feeding, febrile convulsions, and stuff that can really send the kid in for a bad time and we'll probably admit them for include asphyxiating, developing a secondary pneumonia, developing air leaks in their lungs, so then like bullae, which then can turn into pneumothoraces, uncommon but possible, and becoming encephalopathic because they're coughing so hard that they can't breathe, not enough oxygen is getting to their brain and they're getting confused. So have a spiel for if you have this station in OSCE, and maybe, because I remember, I think we had a practice station where they literally gave us a video to watch at the start, and it basically showed an infant having a coughing fit, and off that video alone, they're like, what's the diagnosis? And apparently it was pertussis, and I missed it, and I failed that practice station. So please don't be me. So just run them off, admit them, especially if they're having complications, and if you're not sure, just say that you'll admit them. Run some investigations to kind of make it more likely. Clarithromycin, there are other antibiotics, but just pick one off the guideline, and I like to pick clarithromycin, and we want to treat them for a week. Monitor them, support them with their oxygenation and feeding, and then, because it's an infectious disease, exclude from others until 5 days of therapy or until after 21 days of coughing, and it is a notifiable disease, so you can tack that onto the end of your spiel. Stuff making sense, guys? Happy days? Cool, I'm seeing nods, this is great. Next one. As you guys can probably tell, I spent a lot of time at Dandenong ED, which is why a lot of these stems start with that. Shout it out at me, team. Cool, viral-induced wheeze. Any other takers? Bronchiolitis, cool. So I'm happy that we have a couple people leaning between D and E. Is there any reason why I would want to lean towards one diagnosis over the other? Anyone? Yep. Good. Yep, so now we're sort of going down that path of kid with a wheeze, what is the diagnosis? And so because of the answer here is in fact bronchiolitis, and the feature that leans us away from a viral induced wheeze is the fact that this kid's 6 months of age, so less than 1 year. And I have a really nice slide by a pediatrician who gave us this lecture that I'll show you guys in a bit that helps us differentiate the spectrum of pediatric wheezes. Cool. The buzzword here to be aware of is the high pitch expiratory wheeze. So yep, bronch in a nutshell, RSV, your 3 features that will lean you towards it less than 1 year of age. It's winter. If you guys did peds in winter, you would have seen them in droves. And parental smoking is more just a risk factor for them to more likely to develop any sort of airway infection. And you get, this picture of they have a viral prodrome followed by, generally, feeding less, often just generally miserable, look like they have increased work of breathing, and your buzzwords are generally heard on auscultation, so it's the high-pitch expiratory wheeze and the fine and inspiratory crackles. If it's a clear-cut case, don't need to investigate them. And again, management is dependent upon how we risk stratify them. The features that we're looking at very similar to Croup. So we're looking at work of breathing, saturations, mental state, that sort of jazz. If they're mild, we can educate the parents, hey, it's viral, we can't really do anything for this besides give them, help them with feeds and give them oxygen. Reassure them, send them home, and organize GP follow-up. If it's moderate, we can refer them to peds and ask them whether or not, hey, do you think this kid needs to come in or not? And because the only thing we can really do with bronchiolitis is like the pancreatitis of respirant kids because we only really support it. And the 2 ways we support it is with oxygen or with oral feeds, oral fluids via an NGT. So if the kid is not hypoxic and they're not off their feeds, there's not much we can do besides monitor them in ED. And so for that reason, that's why we would probably just send them home so we can get the next patient in and not break the 4-hour rule. Cool, and if they're severe, they're desaturating, they look lethargic, admit, support their ABCs, consider transfer. If the diagnosis is unclear, this is when you would definitely refer to, flag this patient with peds and be like, hey, I've got a sick kid here, not entirely sure what's going on, send help. Cool, happy days? So this is a slide I stole off Dr. Isaac Clifford, who gave us our pediatric respiratory presentation. And I think this is an incredibly useful slide for 2 main reasons. It helps us, this is the spectrum of kids with wheeze. And what you'll notice right off the bat is that we basically realize that the difference between the diagnosis is mainly the age. And then partly the clinical presentation after that. So as you guys can see that we favor a diagnosis of bronchiolitis at less than 1 year of age, and we favor a diagnosis of viral pneumonitis if it's more than 2 years of age. And you have this really awkward space in between 1 and 2 years of age where honestly you can diagnose either, and it's arguable about whether or not you want to call one or the other. Hopefully in the EMQ, they'll make it clear cut and they'll either make it over the age of 1 or under the age of 1. Viral induced wheeze is sort of this weird entity that exists in the middle where this kid comes in with a viral-like syndrome and have a wheeze. And then you guys may or may not have seen it in ED where, hey, let's chuck some Ventolin at them because it's not likely to harm them. And if it does improve their wheeze, we can then call the diagnosis Ventolin responsive wheeze. The reason we differentiate viral-induced wheeze from asthma is because not all the kids who have a viral-induced wheeze or a Ventolin-responsive wheeze will actually go on to develop asthma. So we don't want to condemn them to, hey, your kid has asthma, they're going to be on Ventolin for the rest of their lives. Let's call this viral-induced wheeze, send them on their way. If they keep coming in with wheeze outside of infections and the like, and they get older, then we can start calling it asthma. Cool, so does this slide make sense? And hopefully it's clarified for you guys a few doubts as to, I'm seeing a few thumbs up, I'm loving it, thank you guys. So yeah, hopefully this cleared up why we throw pretty much Ventolin at everything that isn't bronch, and why we don't want to put the label of viral-induced wheeze. Yep, what's up? They actually had a viral-induced wheeze. So this is, again, so people like to use different terms. So people may have had childhood asthma, and we're trying to move away from that terminology, try and call it now when people come into the ED, like a lot of the pediatricians and respiratory physicians want to call it viral-induced wheeze and not childhood asthma, if that makes sense. We're trying to change the language we use. But so people could say that they had childhood asthma and grew out of it. You probably need to take a better history. Was it wheeze only when they were virally, or were there other triggers to it? If there were other triggers to it, then perhaps it was more along the lines of, they did genuinely have childhood asthma and they grew out of it. Any other questions? Hit me, guys. Can't hear you, can't hear you. So viral pneumonitis versus viral-induced wheeze. In my mind, those words are interchangeable, and I have not seen many clinicians use the word viral pneumonitis, because often the context I've seen a pneumonitis used is when it's non-infective. Or if, so for example, in the case of like meconium aspiration, where it's like an irritative pneumonitis. Sorry, so I guess I don't really have an answer to that, sorry. Anybody else? Happy days? Cool. Cool, we'll move on. Cool, we'll start on our asthma management questions. I really hope this is obvious to you guys because like, you will probably get an asthma station of some variety, either, not an asthma station, you will get asthma either most certainly as part of your EMQs and quite highly likely as an OSCE station. Okay, shout things that you would throw at this kid. Age, cool, so give him salbutamol, great. What else are we throwing at him? Louder guys, louder. All right, I'm just gonna go on because I know you guys probably know. Anyone disagree with me? Hit me, Amber, hit me. Okay. Okay. So the question was whether or not we should just try the kid on some salbutamol, given that they're mild, and we don't really need to throw them under the bus with the full hour of power of ventilator therapy. In practice, you're absolutely right. Kids who have a really mild exacerbation of asthma who come in, and we know what their trigger is, and we don't think we need to actually treat the underlying cause for their exacerbation. You're right, we would probably just give them a few puffs of salbutamol, let them sit down, send them out really quickly with a bit of reassurance. For your EMQs, we would start them on the hour of power. Because this is an option, this is a station where I know that we start them off. Does that surprise you at all? What's up? No, just for this question, Usually they'll pick one, and if this is a question where you have to pick one, I would say pick the salbutamol. That's why I picked multiple options. Like, for example, I really wanted to tell you guys that this kid is not hypoxic, which is why they don't need oxygen. Cool. Any other questions about that? I wrote this question. If it's a bad question, I'll try and fix it for later. I see what you're saying. So the 4x4x4 is the community management, and then we'll have a chat about the dosage that we give them in ED. It's essentially every 20 minutes, either 6 or 12 puffs, depending on how old they are. So yes, short answer, 4x4x4 is community management. Anyone else want to dispute me? Because I'm fairly confident that this is maybe not the best written question, but at least reasonably right, and even if it is a mild asthma attack. Some people might not give the steroids if it's really mild, but I know I've seen very mild asthmas come in where they just start them on steroids, monitor them for 4 hours, and then send them off if they're getting good after that. Question number 2, guys? So this one's just one option. Someone shout the answer at me. I see some confused faces in the audience, which makes me think I've written a bad question. What's up? K? Yeah. Yeah. I need to get, yeah, what's up? So I can't hear you, sorry. Okay, got it. So if that's the case, that is unfortunate. Yeah. Oh yeah, I wanted to make it wrong. Oh, okay, no, I see the issue here because there's 2 options, I see. Yeah, okay. I guess the short answer to this, if this isn't according to the RCH guidelines, follow the RCH guidelines, and if you're given an option, you shouldn't be put in a position where you're picking your own agent as like a 4th year student. I would say if this question is, what's up now? Yeah. So I followed the handbook, which is where this answer came. Whether or not the aminophylline or the mag self comes first, go with the mag sulfate, and you can have the asthma handbook substantiate that claim. So a really quick recap of assessing an acute asthma. And the idea is that the assessment of acute asthma dictates the ladder that you go through. And the idea is that, again, we look through 4 features that we look at. So I like to call it the MOSE criteria. So mental state, oxygen sats, work of breathing, and speaking. So speaking, like I like to use the same mnemonic MOSE for Stridor as well, but that S will stand for Stridor, at rest, or on exertion. In asthma, the MOSE, the S stands for speaking. In a patient with critical asthma, they may have really like intense work of breathing, or maybe they have none at all. They've just had a respiratory arrest, jump on the chest, start CPR. And so be wary of the silent chest or a patient who just doesn't look like they're breathing. Start your BLS stuff. So this is what I wrote up for myself as a spiel that I could have for a patient who is on the stem, is having acute asthma episode. And so you'd be like, this is a moderate severe asthma attack. This kid needs to be admitted. Talk quickly through your ABCs. Positioning is something you can do really quickly so that they can have ease of work of breathing. Give them supplemental oxygen if they're hypoxic. And you guys are probably familiar that the dose that we give them is dependent upon whether or not they're younger than 6 or older than 6. So like I would literally say, give them salbutamol, 12 puffs via spacer and nebulizer every 20 minutes for the first hour, followed as well as ipratropium. Like let's say they're 6 years old, say 5 years old, 4 puffs every 20 minutes for 1 hour, and start them on oral prednisolone. Come back and reassess them in 1 hour and see if that has done anything, and reassess those 4 fat features that I looked at before. And then if the examiner comes back to you and says, hey, they're not improving, I'd like to start them on IV mag sulfate, perhaps consider transferring them to ICU at 50 milligrams per kilogram over 20 minutes, and so forth. So this and DKA are 2, and if I'm wrong in terms of the actual dosings and you find that there's a discrepancy in terms of the RCH or the handbook, follow those numbers. But the idea is that if it gets worse, you should be able to like rattle off the dose and route for your OSCE as well, not for acute asthma, and for your and for DKA stations as well. Is there anything on this slide that feels blatantly wrong to any of you? No. So what's up? The first 3 usually. Sometimes, so the problem with EMQs and just this particular, and asthma specifically, is that you will see clinicians do various things for mild cases. Some, like Amber pointed out, I've seen plenty of clinicians who have started on just salbutamol alone, don't need ipratropium, don't need oral pred. Usually you would start them on both salbutamol and the ipratropium. I've seen judgment calls about whether or not you start them on pred or not. I would say that if you needed to, in your OSCE, it would be safe and reasonable that even if a kid has had a mild attack of asthma and they've come to ED, it'd be fair to give them salbutamol, the ipratropium, and oral pred right off the bat, watch them improve, and then if they're getting better, then we can start working our way up. The way I look at it is that in your OSCE, if you don't say enough, you will not get the marks, but if you say too much, at least you've hit the points that you could have gotten. Does that rationale seem fairly appropriate to you guys for OSCE land? Yeah, they weren't, ooh, fair. Yeah, I didn't talk and say anything about this kid being hypoxic. I guess in my mind, I was working up the ladder, if that makes sense. It was more, so it was less a question about not giving them oxygen. We probably would be giving them oxygen at that stage and they probably would be hypoxic. I just haven't incorporated that into this EMQ. Does that make sense? So you would give them oxygen if they're hypoxic, and they probably, if they are needing magnesium sulfate, they're probably sick enough that they are probably desaturating and need oxygen. Cool. Cool, next question. Anyone have an answer? Moderate persistent, anyone else? Cool, so I'll just take it from there. So this is in fact moderate persistent asthma, just based on the fact that this is not an acute flare. This is in the GP setting. The kid is quite well at the moment. It's an ongoing issue, and this kid's having nocturnal symptoms most nights of the week. And I'll give you a really quick rundown of how you can stratify the chronicity of asthma. And essentially, the way that we can broadly divide it into either intermittent or persistent, and then within intermittent, we can call it frequent or infrequent, and within persistent, we can call it mild, moderate, or severe. And this might look like a lot of information, but you can actually figure out where the kid lies in the spectrum in 2 questions. So actually, my GP uses it on me because I'm an asthmatic, and he's like, hey, how often do you use your salbutamol? And I'm like, what do you say? He asked me, less than once a week or more than once a week? And I'm like, less than once a week. And he's like, less than monthly or more than monthly? And I'm like, about monthly. And then he just put me, probably typed in his notes, frequent, intermittent, if you really want to. I'm not sure this is something that is really obviously done, especially in ED, but it's something that you may have seen documented in terms of chronic use. And you guys are probably familiar with the chronic management of asthma in terms of the asthma step ladder. What this list doesn't have is the step down part of it as well. If the kid is doing well, they're not getting symptoms, and that's not something they would probably expect you to do as part of an OSCE station, like identify a child who is actually being over-treated and can probably have step down therapy. But this is like the general trend that you can look at, and hopefully none of this is new to you because it's very similar to the way we step up therapy in adults as well. Question? No. Cool. Now, this is the busiest slide in the whole presentation. You will never be expected to do this as part of a single station, but I just wanted to give you guys a bit of a framework as to how to think about asthma and history taking depending on what sort of OSCE station you guys get. Because in my mind, I like to break it down into questions regarding past, present, and future. And depending on what sort of OSCE station you get, you can ask the relevant questions to get as much information out. So if it was a GP asthma station and you're doing, it's not clearly a 10-step, it's a 10-step management plan, but they ask you to take a history at the start. You can, do a bit about present, like start with overriding, like when it was diagnosed, what are your triggers, how is it impacting you, and then develop that a bit of that 10-step management plan before you jump into it so you can hit those marks. If this is like an acute asthma station, you'd be asking questions about the present mainly, and you probably won't be worried about optimizing their future function just yet. And if it's a counseling station about, for example, using asthma devices and whatnot, you might be asking them, questions like, how do you use it normally? Can you show me? Stuff like that. So it's just a matter of like getting an idea of where this kid has been in terms of their diagnosis, what triggers them, and then how is it impacting them, and can we increase their chronic therapy so that they are better controlled in the community. What's up?
Just jump back one slide.
Mm-hmm.
Is the infrequent intermittent and frequent intermittent the wrong way around, or am I just seeing things? Like
No, I think that's right.
Oh, sorry.
No. All good. No. I do things like that. So if people do pick up like weird typos and stuff like that, all good. It makes sense to everyone else? Cool. No problemo. So, so just some questions that you can ask, and you can figure out what questions you need to ask depending on like how acute the presentation is or how chronic the presentation is. Hopefully you guys find this slide useful, because I have, especially in like ED or in other settings where you want to get a good overview of their asthma. And like, as you guys have probably realized in kids, a lot of kids tend to be quite healthy with acute on chronic issues and with single medical issues. So if the kid has only come in with asthma, and we know asthma comes in droves, taking a really comprehensive history of someone's asthma in the ED or in a GP clinic can really wow your consultant or whoever's like looking after you and be like, hey, this student has a really good grasp of this patient's asthma. Cool. This is the last couple of slides, and yeah, we only have a few minutes to go. So this is just a little bit of didactic teaching. We're not actually going to go into any questions about cystic fibrosis. I think it's pretty fair game that on the chronic end of respiratory, that you might get a station where it says, kid has had a recent diagnosis of cystic fibrosis. Please counsel mom as to what this means for her kid. And you should just be able to know some stuff off the top of your head to be able to go through your explanation of it. So we just remember cystic fibrosis, mutation in the gene that codes for chloride channels. I'm a simple man. I don't like to remember anything too much more difficult than that. And the idea is that because of these channels are defective, they get excessively thick mucus in multiple organ systems as a chronic condition with no known cure. You should be able to explain the very basics of the inheritance pattern. And if you draw Punnett squares in your OSCE, bonus points, telling them that we know that it's an autosomal recessive condition. And if you get the classic station where neither parents have cystic fibrosis, you can tell them, hey, look, you're both carriers, which means unfortunately your kid ran out of luck. They were the 1 in 4 chance of developing cystic fibrosis. And then you can either tell them there's like genetic testing in the future for them to plan future pregnancies. You can tell them like, this might have been picked up on a screening test, such as the Guthrie heel prick, and the specific component of the Guthrie heel prick is the plasma trypsin. And then they can then move on from that screening test to a diagnostic test, either finding that high sodium in their sweat, or doing the test for the actual mutation in of itself. If you want to tell them like there's a specific gene that is usually mutated on chromosome 7, you can tell them that. We know that there are other mutations that can cause cystic fibrosis as well that are not as common, which you don't need to go down into the genomics of with the parent. Most of the time, if you guys have seen clinicians counseling patients about new diagnosis of chronic conditions, it's less about what caused it and what it means for them that matters to the patients. So in your OSCE, they love the buzzword, this is a multidisciplinary team involvement, and depending upon what sort of problems we anticipate your child will have, we can get different people on board, and this can be different doctors. So maybe a GP to be the linchpin of the child's management, a respiratory physician, gastroenterology, and maybe even a pediatrician early on, and then allied health individuals as well, so nursing, social workers, support groups, and the like. And the 3 arms of management when it comes to the chronic management of cystic fibrosis is the respiratory side, with the goal of preventing the progression of their lung disease. So giving them bronchodilators to help them open up their airways, mucolytics to help break down that sputum, and then chest physio to help them expectorate it. Prophylactic antibiotics, we know that these kids are at increased risk of going on to develop lower respiratory tract infections. And then very late on in the game, this is not something that you necessarily have to tell the parent, is that, if their lungs really get messed up and they're healthy, reasonably healthy, we can consider lung transplants down the line. In terms of the gastroenterology side of things, we want to make sure that we want to optimize their pancreatic and nutritional status. And so giving them a high calorie, high fat diet, because they struggle to absorb that fat, because their pancreas is plugged up with mucus, they're not able to break down fats easily. So we're going to give them a really energy rich meal so that they can absorb as much of that energy as they have, because this is a disease that really eats up a lot of their energy. Get a dietitian on board, because if the kid's a picky eater, because every kid is a picky eater, try and optimizing it so they have as nutritious meals as they possibly can. And then we will see them regularly, tracking their growth and making sure that they're not dropping centiles and the like. And on the psychiatric side of things, this isn't just a big thing for the parents, it's a big thing for the kid once they get old enough and start to grasp that they have a chronic and pretty debilitating condition. And so, getting them counseling, getting them linked in with support groups, finding, other peers with cystic fibrosis that they can relate with can help minimize the side of like psychiatric complications like, depression or, and stuff like that. I'm pretty sure this is the last slide. If the parent's like, oh, what do I need to worry about in terms of my kid having this condition? We tell them, unfortunately, this is a life-limiting condition, but then you can have that positive spin on it, with adequate treatment and, making sure that we optimize everything we can. They can live into their 40s and 50s. On the respiratory side of things, things we worry about include recurrent lung infections because that mucus sits in their lungs. We usually are able to clear it out, but in your case, your kid has it produces a lot of it and has difficulty bringing it up. That can act as a medium for bugs, and then they get chest infections. And then bronchiectasis, because they have that ongoing inflammation of their lungs, it destroys the airways, and for that reason, they have permanent deformation of their actual lung tissue, which you can tell the parent we call bronchiectasis. We can talk about the GI complications. So because of the fact that like the biliary tree and whatnot or like the tubes that lead from the pancreas to the intestines are blocked, they can't get the substances that would help otherwise break down food. And so for that reason, they don't absorb as much. They get malabsorption. They can get dehydrated. They can get constipated. And from the reproductive end of things, you can just tell them that like for males, because the tube that normally carries sperm is usually blocked with mucus. And for that reason, males are generally infertile, and women with cystic fibrosis often find it difficult to conceive. So that is it from me. I hope I'm done talking at you guys. I hope you guys learned stuff. And if you found this easy, that makes me happy because you guys will probably smash your EMQs. Peds is fun, and I hope you guys enjoyed your pediatric rotations. And if you have any questions, find me on Facebook, come down, ask me questions, and yeah, good luck with the rest of the year. 50 is fantastic. Look forward to it. Yep. Yeah. What slide? Which slide is it? This one? Yeah. Oh, I'm so sorry. So tell them to look at, so for the people who are watching this at home, have a look at the pediatric respiratory slides that I put up for the introduction lectures. And it's basically a mnemonic that goes through the different triggers of asthma. And I cannot remember off the top of my head. It's like allergens, airway irritants, beta blockers. What does C stand for again? Yeah, reflux, all that sort of stuff. And they'll find it there. Cool. Get out of the way.